Hello, good morning, and welcome to 100% Optical Online, and the second of our webinars on today's CT program, which is brought to you in partnership with the AOP. If you missed our first session this morning, that is available on demand on the same platform, but you won't get CET for reviewing that content, but it's there if you want it. I'm Ian Beasley, Head of Education for the AOP, and I'll be hosting today's webinar, while my colleague Molly is on hand to answer any technical questions. And just a few housekeeping points before we get started. So the presentation will run for about 45 to 50 minutes, and then we'll have around 10 to 15 minutes at the end reserved for any questions. There's one interactive CET point associated with the webinar, and we'll upload points in the next 10 working days. It is worth stressing that you need to attend for the duration of the session to be eligible for a point. There aren't any polls on this webinar. There were polls on the previous webinar, and there will be some on others that you may attend later in the day. It's best not to view those webinars through a phone. It's really tricky trying to answer the polls, but don't worry too much. It won't affect your ability to earn a CET point. If you have any questions, then if you can use the chat function at the bottom of your screen, and we'll try and get to as many of those as we can within the time frame. So let's make a start. So I'm delighted to welcome Simon Browning, who will show how the use of ultra-wide field imaging greatly enhances the ability to detect and analyze changes in the peripheral retina using conventional structural imaging, as well as functional retinal analysis using autofluorescent imaging. He'll also explore the latest use of this imaging technique when combined with integrated OCT. So Simon, over to you.
Thanks very much, Ian, and good morning, everybody. Nice to be with you. What I want to look at today is really looking at multimodal imaging and the benefits of bringing all these imaging techniques together into, if you like, into one box, and the benefits of the additional data that we get from that in terms of analysing images for the benefit of the patient. Multimodal imaging is actually fast becoming almost a standard as a result of the pandemic. If no other reason in terms of practices, the sheer sort of practicality of keeping the practice as biologically clean as possible for patients and staff to prevent spread of infection. So obviously it makes sense, the more instruments a patient is going to sit at throughout the whole of their examination, the greater the risk of spreading infection, and the more sort of cleaning's got to take place afterwards. And this not only looks at infection control, it's also looking at the actual time management within the practice. Some instruments may be in different rooms. The fact that you have to give different instructions to patients each time they go to a different instrument on how to use it, all of these things have an effect on time management. And you may have noticed, it's interesting when you look at the adverts, just how many manufacturers now talk about their instruments being COVID friendly. You can remote image, you can do everything from a distance with these. So you can see how this is all becoming the norm now. And it's really important in practice to have a streamlined patient flow to maintain that patient throughput through the journey. And we know from the Optos survey that's been published recently that patients want us to be using this latest technology. They care about their vision, and they want the highest standard available to them. But they don't want it because they want to know everything's wrong. Quite the opposite. They want to be told everything's okay. They want us to use the instruments to prove that they're healthy, not ill. And that, of course, presents us with a dilemma, because more technology suggests that more is seen, and potentially we've got more liability as a result. And practitioners are becoming more and more concerned about being sued by the patient, heading up in front of the GOC Fitness to Practice panel. And one of the results of this increased technology is either over-referral to overburdened busy secondary care sectors, or over-monitoring of a patient, just to be sure and just to protect ourselves in case anything goes wrong. And one of the things I spend a lot of time doing now when I'm doing training and education systems with individual practices and practitioners is we spend more time looking at how to analyze images properly so that we treat that data properly, and we keep the patient sort of away from undue sort of hospital visits or revisits to us, and we keep the practice from chock-a-blocking its books, its appointment books with people being followed up who don't really need to be followed up. You know, patients don't want to be unduly worried by undue returns to the practice for extra scans or to hospital visits. There's what I would call a waste of resource and a reputational risk there to the practice of doing this sort of thing. With the correct tools and with the correct knowledge, this isn't an issue, and I hope to demonstrate that today. Ease of capture obviously is really important, and so the advent of these multimodal imaging devices is clearly a great breakthrough. Now, obviously, OCT is becoming more and more the sort of the buzz in practices, and it's good. And I'm never going to decry OCT, but it does currently have traditional limitations because it just doesn't image well in the periphery. Some devices have modifications that allow you to look slightly wider out or a bit wider out, but most OCT devices, we're using those to image that central portion of the retina. Eye steering can solve this to an extent, but patient cooperation with eye steering is essential. Quite often the technician needs to be quite highly skilled to get good results from the patient. And coming back to the patient flow, it extends patient time. And so, you know, this can cause problems within a busy clinic as well. And often we're looking at montaged images, but are not always clear due to overlapping. There are devices that will get around this. I'm going to be talking about the Optos Silverstone. This is a stunning new piece of kit, and hopefully you'll see this as we go. The Heidelberg Spectralis, obviously with an additional lens, brings us out into wide field imaging, and we've got the Canon OCT there as well. But let's just look at what's available to us in practice. Obviously, to keep all the toys in one box, we've got the Monaco system. This gives us true ultra-wide field imaging. We've got a 200-degree image capture in sort of one single image, and a 40-degree wide field OCT built into the system as well. This OCT is using spectral domain imaging. And you've got your modalities there. You've got the Optomap with Optomap Plus software, giving you a composite color image, as you can see on the right there. And you've got your autofluorescent image, and more about that as we go. And you've got an OCT built in there as well. And the whole system runs on, you can use it as a multi-mode imaging system, whereby image 1 will give you your Optomap image. Image 2 will give you an autofluorescent image. Image 3 gives you an OCT raster scan. So this greatly speeds up the process for the patient, all sat at one machine, one set of instructions, one set of data in one set of software for the practitioner to then analyze. So with your Monaco, you've got a wide field line scan in the OCT, you've got a wide field raster scan, retinal topography scan, optic nerve head topography scan, and the RNFL circle scan. So quite a standard set of images available to you within that. If we look at the Silverstone, now the Silverstone is the latest in the family. Again, you get a 200-degree image of the retina. This time you've now got an ultra wide field guided swept source OCT imaging device in there as well. And now with this device, as you can see again from the images on the right there, OCT imaging is possible anywhere within that Optomap image that you've captured. Again, you've got a high resolution Optomap Color and Optomap Plus system. You've got your green laser and your red laser, so you can look at different depths of the retina. You've got an autofluorescence imaging in there. You also, with Silverstone, have Optomap fluorescein angiography capability, indocyanine green capability, and as I say, the swept source imaging. And again, you have this multi-mode imaging available to you with the color, the AF, and the raster scan coming as a set program within which to image the patient. So you get a screening set of images there for the clinician to look at before moving on to greater depth images as you request them. Just a little bit of detail about the OCT types again there. for those that are interested in just what's available within the machine. And you can see there the line scan, you can have variable widths of a 6, a 14 or a 23 millimeter scan there. Now, it's quite beautiful because, again, you take your Optomap image and then literally on the imaging tablet, you can move the cursor anywhere you like within that image to achieve your OCT image. So literally by moving your finger on the screen and just moving that image around, that line or that box around anywhere you want to on that screen, that is the area that you will image. And you'll see some images later on showing you just how brilliant that is. Again, you've got your ultra wide field line scan at 6 millimeters, a volume scan, high definition volume scan, and this extended line scan across the retina. And you can begin to see here the amount of image you can see at any one time within that scan. So within one set of images there, you can look at the retina in color, you can look at the different depths, you can look at the actual functionality of the retina, and now you can see the OCT image as well. And these combined modalities give the clinician a fuller picture. You've got a structural analysis and a functional analysis of the retina, which gives you greater accuracy for treatment planning. The functional analysis, the autofluorescent image, gives you a real-time view of the metabolic state, the metabolic functionality of the retina. And the structural analysis allows you to determine the damage caused by metabolic malfunctioning. Ultra wide field images allow you to assess the widest possible area, and combining all of these into that one instrument allows you much greater use of analysis. The image capture is quicker, the patient doesn't need to move between instruments, and it's just literally that one set of instructions for the patient to adhere to. And I would just like to touch on one little thing here, which is the billing. Everybody gets worked up about who pays what. One of the great things the Optos survey showed us, patients are willing to pay for these things. They want us to use them. They're willing to pay for them. But the problem is if you've got lots of different instruments and you say, well, we're going to charge you 50 for your examination and 30 for your Optomap scan and 30 for your OCT, patients just feel they're having things racked up on them sometimes. And I've known instances where patients have said, well, you choose, I can't afford all of these, you choose which is the best one for me. And of course, there's all sorts of dilemmas there. So by putting everything into one box, you build it into one single charge for everything. And again, I'm always a firm believer nowadays of financial plans within practices to build all of this in, but that's for another lecture. So let's just have a look here. We've got an autofluorescent image, an OCT line scan. Now, looking at this OCT image, we say to ourselves, is this dry AMD? What have we actually got going on here? The hyperfluorescence shows this ongoing retinal stress and that the retinal pigment epithelium is compromised. The hypofluorescence shows retinal pigment epithelial atrophy, or what I term cellular dropout, because it's a nicer phrase for the patient to deal with. And you can see the characteristic lace-like autofluorescent changes related to decay of the RPE in the periphery, and some on the left-hand side, some peripheral retinal atrophy there. Now, if we add that OCT in at the same time, that addition of OCT imaging immediately shows us that we've got dry type AMD going on there, classic appearance of dry type AMD. And so adding that OCT image onto that autofluorescent image immediately gives us more information, allows us to decide what we want to do with that patient. We don't need to refer that patient in now that we have the additional evidence of the OCT there. Now, again, this is using the Optos Monaco. We've got the patient sat there. We've got this image here. It's a bit of activity going on in the center. There's a sort of blurred area of activity adjacent to the fovea. There's a darkened area of increased activity by the looks of it below. But what is it? Is it macular degeneration with neovascularization? Is it adult vitelliform degeneration? Very difficult to tell from a standard structural image. The autofluorescent image gives us more information. We've got the generalized area of shading at the top here. Now that could be due to subretinal or intraretinal fluid. We know it could be fluid, but we don't know where it is. The hyperfluorescence of increased lipofuscin shows we've got compromised lysosomal activity in the retinal pigment epithelial cells. and we've got some atrophic cellular dropout. So we know the retina's under stress, but we still can't define categorically. Now, because we've got the OCT image built into the same system and we've got that available to us, it shows it's a vitelliform detachment and there's reabsorption of the vitelliform material there. And we can have a look at that, and we know that we're not going to confuse that with subretinal fluid related to wet AMD. So once again, having that OCT image alongside the standard retinal image, this assists us in the decision on any treatment or whether to refer or monitor. And so immediately that information gives us much, much more detail. We can put notes on our record cards about the patient much more thoroughly. If we decide not to refer, we've got the images there, we've got the decision-making process behind that recorded on the image and on the patient's records. So again, we know more information for the patient, and we've got more information for us to show that we've done the right thing. Another classic case we see time and time again in our lives, scattered soft drusen throughout the posterior pole, early dry AMD. Is there anything that we can do to resolve this? I was watching a CET thing the other day that said that drusen on the retina, once drusen are there, they're there permanently and they're not going to go away. I personally happen to believe otherwise. We have, looking at the autofluorescence scan, we can immediately now see we've got increased background glow of fluorescence. This is consistent with age, it's consistent with the RPE cytoplasm filling up with undigested lipofuscin. Let's not forget, at 70 years old, 70% of that RPE cell is full of lipofuscin and preventing good normal metabolic activity within that cell. So you'd expect to see that in an older person. The metabolic functionality of the macula appears largely uncompromised. It's a good clinical sign, but can we be sure of that? So let's look at the OCT, and immediately we can see the foveal region is appearing healthy. We see the drusen along the base of the RPE. We see evidence of vitreous detachment there. So we know that the prognosis here is good, is reasonable, or is it? Are they doomed? So let's look at a real case study from my practice. So we've got a 64-year-old patient referred because the GP was unhappy. He's been told he's got AMD and that nothing can be done for him. His brother's severely sight impaired with wet AMD. He himself is overweight. He smokes. He's got a poor diet. Then you can see the vision in that right eye is down. When we look at his images, we've got their classic soft drusen around the foveal region. We've got classic hyperfluorescence we can see in that lower left image, hyperfluorescence consistent with that drusen and the macular degeneration changes. And there on the bottom right there, we see a classic OCT of dry AMD. And that tells us all we need to know at this stage. This patient has dry AMD. What's the outlook for him? Well, what we do with these patients is we sit them down, we talk to them about stopping smoking, about improving their diet, about weight management, obesity management. We talk to them about their diet, what they need to be getting in there to get the right antioxidants into their lifestyle. And in this case, this person had drusen at both macula. We're putting him onto dietary supplements. And he's great. He comes back, he stopped smoking, major improvements to diet, lost weight, far more active, using dietary supplements. And look at that visual acuity. It's now gone from 6.9 to 6.5. And now when we look at his images, we see that top color image there. There looks to be a lot of lost drusen in the center. Now, people might say, well, that's geographic atrophy. It's just died, isn't it? But if it had died, would it really have gone from 6.9 to 6.5? Wouldn't it have gone the other way? And then when we look at the autofluorescent image, we see that macular region, that foveal region, now looks to be pretty much normal. It looks to be fluorescing the way we would want it to fluoresce. And look at that OCT. And because we've got that integral OCT built in there as well, we can see what's happened to that macular region. We have reversed what was going on there. And to this day, this guy stays like this. So this is really, really important to us. If we look at his other eye, we begin to see over time changes at his nerve head, and we see on the autofluorescence scan some hyperfluorescence occurring, and we begin to see a sort of schisis appearing at his nerve head there. And later on, that schisis moves on more And again, we can vividly see this by use of the multimodal imaging, and we've got the OCT there. His vision in that eye is now dropped to 6/9. No treatment for that. If we hadn't sorted out that right eye, where's this guy going to be now? So we see by use of this multimodal imaging how we can help these patients. The autofluorescent imaging allows us to see the functionality, gives us that functional information we need to inform our decisions and the patient. The OCT shows us what is happening structurally within the layers of the retina. And we can now use these tools. And I always say to people now, optometry to me is not about vision correction as it was traditionally. It's about vision preservation. We need to be talking to our patients about stopping smoking, dietary habits, weight management, exercise. All of these things, as our patients live longer, become vital to our everyday practice. I like to think of us now not just as vision correctionists, but vision preservationists. That's the way forward. And this is where this data gives us all of this. And I just show you here the sort of screen base you get when you take an image. You can see in the study layout there, you've got 3 bars. This particular layout gives us the color image, the autofluorescent image, and the OCT image at the bottom. So we can look at this patient on one screen, having taken one set of images, and see what's going on. And if we just analyze in a bit more detail, there's some scattered drusen around the posterior pole, possible areas of geographic atrophy, potential scuffing of the fovea. But we really, again, don't know what's happening here. The autofluorescent tells us a bit more with the increased background glow. When you look, there is no sign of hyperfluorescence in the area where we said, ask the question, is that geographic atrophy? We now know it's not geographic atrophy. So with no hyperfluorescence there, we know the RPE functionality is not compromised in that region. And then when we look at the OCT, we can see a classic epiretinal membrane there, the characteristic pulling up of the fovea, but with a normal RPE layer. So now we've got a full history of that patient. We can see the structure, we can see the function, and now we can see what's happening within that macular region. So we can sit and talk to the patient about expectations and what's going on in the full knowledge of what we're doing. Now here's a diabetic here. Obviously had a lot of panretinal photocoagulation in the past. Can you tell if the macula's compromised looking at that color image? I can't. If we look at the OCT image straight away, having been taken at the same time as we took the color image, we can see clearly pronounced diabetic macular edema. This must influence our thinking. It must influence our referral process, and we can refer accurately and timely because of that multimodal approach to that patient. Again, we've got a retinal inferior branch retinal vein occlusion, classic sign there. Is there macular involvement? If so, how much? There looks to be involvement because there's blood there, but how much? You can't tell from a color image. You can certainly see from an autofluorescent image the blood far more. You can see apparent hypofluorescence centrally, which probably means it's due to edema, but you can't tell the extent of it. By bringing in the multimodal image and bringing the OCT image to play as well, you immediately see the extent of the edema that's there. This you can send to the eye clinic. This will influence any treatment plan at the eye clinic. It will influence the speed of referral from our end as well. We have another one here where the macular region appears essentially normal. And again, if we look at the autofluorescent image, looking at the functionality once again, there's a small area of hypofluorescence, but no hyperfluorescence. So the absence of hyperfluorescence would suggest that there's no active compromise to the retinal pigment epithelium. So that's good. That's a good sign. Introduce the OCT in there, and you have a pseudomacular hole. This immediately confirms to you there is no compromise to the retinal pigment epithelium. And so if you're thinking, well, is this a macular hole that needs immediate treatment? I've got to get them there as soon as possible. This will change your thinking. This will inform your thinking far more. So by bringing these images together, you've got a far more complete set of evidence, A, for you and to record, B, for you to inform the patient, and C, to inform the clinic if you wish to make any referral. So I want to look at Silverstone imaging now, because this is, to me, really, really exciting, because many of the sight-threatening retinal defects lie in the peripheral retina, and often in asymptomatic patients, do we even know they're there a lot of the time? So many times I've seen patients with peripheral pathology who've had many, many eye exams in the past, and they've never been told about things that are there. When a lesion is found, how do we assess the potential for development of more severe pathology? How do we decide on the urgency of the retinal referral? So the following slides I'm about to show you have just been taken from a recently published paper, and I'd like to give my thanks to the people who've allowed me to show you these today. The paper is noted there. And what I want to do before I go any further, I just want to bring back to you these definitions we use. We use wide field and ultra wide field an awful lot. With wide field imaging, we're talking of an image up to and including the vortex vein ampullae in all 4 quadrants in a single capture. We're not montaging here, this is in a single capture. So when you look at retinal imaging, you're looking at the Optos and the Zeiss family of instrumentation mainly. There are, of course, others appearing as well. But when we talk ultra wide field, we're talking of a 200 degree. We're talking of an image beyond those vortex vein ampullae, again, in all 4 quadrants in a single capture. And true ultra wide field imaging, we are sitting with the Optos family of instruments. So it's important that we understand what we mean when we're talking about wide field, ultra wide field. This is now formally defined. You can see that classification that was accepted internationally at the bottom there. Now, in this paper they published, they were saying that, does peripheral OCT help in the management of a patient? And you can see here, if we look at 13 patients they saw with retinoschisis, in 8 of those patients, 62% of the patients seen, the use of peripheral OCT guided the management of that patient. 62%, 8 patients out of the 13. And as a result of that additional information, 1 patient achieved treatments they wouldn't otherwise have received. Retinal detachment, in all cases of retinal detachment, ultra-wide field OCT imaging guided the management of that patient. And in 2 of those patients, they received treatment they would not necessarily have achieved before. Retinoschisis with retinal detachment, again, every case of retinoschisis, that additional information allowed them to be able to manage the patient better. So you can see from this table here alone, just that additional information of guided ultra-wide field OCT. So ultra-wide field OCT guided their management more. So let's have a look here. We've got an inferior retinoschisis here. We're all used to retinoschisis. This one's quite a large area here. And you can see the 4 lines on there, and they equate to the different images. Look at these fantastic OCT images from the periphery here. So if we look at area B, we see that there is an apparent shallow retinoschisis. It's located temporally, and it correlates with the orange mark on there. And we can see there that the retinal base is perfectly okay, and a classic view of pure retinoschisis. If we move further across, slightly still lower temporal, but a bit nasally, we see this deep bullous cavity you get, a much more developed retinoschisis. And that was noted further along. And you can see just to the side of that, closer inspection shows the outer retinal break with sort of rolled margins around that break. So we've now got a break in the retina as well. But it would appear the retinal base is still looking sound. So this is good. But now, when we move a little bit further up, away from that break, we now start to see subretinal fluid. And so now we know we've got a little bit of change there, but it's not enough. It was thought, now with that extra information, we've got enough detail here to say, okay, it's a retinoschisis, there's a break, there is some fluid there, but we can monitor that. We don't need to run the risk of treating this patient. And so they didn't treat the patient. They saw them again 6 months later, and everything was still okay. There was no progression. The patient is now safely being monitored. And without the ultra-wide field OCT, you just could not make that judgment call. And if we look at retinoschisis versus retinal detachment, we see on the left image here a typical asymptomatic retinoschisis. The retinal base is integral. There's no damage there. And subretinal fluid, you get these occasional subretinal fluid cuffs that can be seen next to the retinoschisis. We're not always going to treat just because there's a subretinal fluid cuff there. They can be monitored routinely. And with the use of ultra-wide field OCT, maybe we would refer to the hospital to get an initial opinion. The hospital comes back to us electronically and says, no, we're happy for you to monitor that. So if you've got ultra-wide field OCT, you can monitor these patients. If you've got subretinal fluid in a symptomatic patient with a retinal detachment, you can see the fluid is in a different position and you can see the retina is detaching here. And sometimes you will see these degenerative retinal cysts, and they can occasionally be confused with a chronic detached retina that's maybe settled back down again. Or you ask your question, is it that or is it retinoschisis? With an ultra wide field OCT image, you can come to that instant conclusion that this is actually not a retinoschisis. This is a chronic detached retinal cyst. Now, lattice degeneration is something we come across an awful lot of the time, and generally they're asymptomatic. Lattice degeneration occurs in 10% of the general population. Now, if you think about that, that means that if you're seeing 10 patients a day, you're probably seeing lattice degeneration in at least one patient a day. Ask yourself the question at the end of this, is that how much lattice degeneration you see? Do you see about one patient a day with lattice? If not, it might be worth asking the question, why not? But the really, really important thing out of all of this is 1/3 of patients with retinal detachments and have no other compounding factors are shown to have lattice degeneration. So that is a really high number. And so, lattice degeneration is a big, big issue for optometrists to be spotting. Much lattice degeneration obviously is in the far periphery, and therefore it can be missed on asymptomatic patients just using conventional imaging. And vitreoretinal traction, as the vitreous begins to peel away from the retina, exerts real major forces on the retinal surface during PVD. So this leaves patients with lattice degeneration at a really greatly increased risk of retinal detachment. So again, if we look at some images of lattice degeneration, we see the classic inferior lattice degeneration in the color image, and we see some little retinal holes there. And look at these wonderful images on the right here. And if we look at area B on here, we've got a retinal hole there. But what you can also see is the ongoing massive vitreous traction and the sort of force that's associated with that. And again, if we look at area C here, we can see another, what looks like an atrophic hole in an area of lattice. Once again, the OCT confirms that there's subretinal fluid there, and there is marked ongoing vitreous traction. This chap, because of the ongoing vitreous traction, great risk of a major retinal tear there. And consequently, with the additional information that's provided to us here, we can make the decision that we need to carry out a barrier retinopexy just to prevent further problems in the future. Now, you can't make that decision definitively without that ultra-wide field OCT. So we've got another issue of lattice degeneration here, and we see beautifully on the right there, magnified up. When you're looking at lattice degeneration, you should always magnify that area of lattice just so that you can get much more information out of it. And you cannot tell from those color images whether the retina has got fluid under it. So we look at the images that we see here, and immediately we see in all of those images, the retinal base remains intact. So we now know that that area of lattice doesn't need referring, but the patient needs to be made very, very aware of the risks that are there to them and why they should come back and see you if they notice symptoms. You don't necessarily need to monitor them on a very frequent basis. You need to monitor them routinely, and they need to be aware of what they should do and if the reasons why they should come back sooner. But if you've got the OCT image there as well, that will guide you so much more. And again, the retinal base remains intact in these images as well. So we know the retina is not detaching, but look at the extreme forces that are there on the retina. Another lattice degeneration here. And again, look at the obvious powerful traction forces that are at play on the retinal surface. This is why it is so important that on every patient, especially 40 onwards, when they're going to start getting PVD, it's absolutely vital to view the far periphery, especially in myopes who are at greater risk anyway. These tractional forces on degenerated retina can easily lead to retinal tears. So important to look in the periphery, and so important if we've got the ability to OCT those areas if we can. Just look at I just think the images are wonderful. You can see the extent of the forces at play on that peripheral retina. And is this hole here within the lattice degeneration a problem? We know it's there. How many times do you ask yourself the question, should I refer? Shouldn't I refer? And again, if we look here, we've got ongoing vitreoretinal traction in an area of lattice degeneration. The retinal base is well attached. There's no subretinal fluid, but the traction on the retinal surface is ongoing. So monitoring a patient like this with advice, essential. If you've not looked at a patient's peripheral retina like this, and you've said to the patient, oh, your eyes are fine, then that could be putting the patient at risk. What's more, it could be putting you at risk, because if there's something else going on within that area, it just might develop into one of those, which is a retinoschisis, a hole, and a detachment as a result of that. And again, when we look at these images here, we see beautifully the subretinal fluid that's there as a result. So retinal holes, they're so often difficult to sort out. Traditional methods of assessment, is there an operculum present? Is the operculum away from the hole? Is it smaller than the hole? Is there a cuff of fluid? Are the margins well defined? Are the margins pigmented? Are the underlying structures clearly visible? Often the decision is, oh, I don't know. I'll do another image just in case, so that if the retina comes off and I get in front of the GOC fitness to practice panel, I can show that I was taking due care and attention. So often we needlessly get the patient back and needlessly worry the patient, or we needlessly refer them to the clinic. This is taking up clinic time in a really busy clinic, or needlessly worrying and frightening the patient. Think of the reputational risk if you unnecessarily worry a patient. So here's a retinal hole here, and we see that line has been put through by the clinician through that hole to do an ultra-wide scan on it, and beautifully here we see the OCT, the hole is flat, and because of the additional information we gained from the OCT, we know that hole is sealed. And you see the lovely shadows where these blue arrows are on the left-hand side, showing that pigment that is sealed around the hole. So often when we're looking at an ultra-wide field image, we go to the red channel and you can see that ring of pigment around the hole to ensure that that hole is well sealed. Retinal tears, again, peripherally, you can now see what's going on the hole area and the tear area, and you can see if there's any fluid underneath the retina. Fantastic vivid images that allow you to see what's happening to that retina. So the red arrow, again, showing the ongoing traction on that retina. The vitreous is still attached to the surface of the retina. It's going to pull and pull and pull. So this should immediately define whether we do treatment, and if so, how quickly we do that treatment. The decision was made in this case to treat not just the break at B, but C as well, because there was so much vitreoretinal traction going on there. So again, another beautiful image there. Now, one of the big things here, nevus. When is a nevus, and when is it something nastier than that? Again, in studies that have been done, it's normal to see as many as 80 to 100 nevi in a week. And that's not unusual at all. The risk of a nevus altering to a malignant state is low. Various figures, 1 in 8,000, 1 in 9,000. As you get older, it becomes far more prevalent. But that's why you should routinely review all nevi. Nevi will enlarge normally in younger patients as their eyes grow, but if you start seeing a nevi enlarging in a developed eye, you've got to be very suspicious of that. A nevi with overlying drusen are probably long-standing and benign, but nevi with lipofuscin over the top of them, and that will be seen as hypofluorescence on an autofluorescent image, they're not nevi, they're probably a melanoma. That's why often you will see autofluorescent, hypofluorescent lipofuscin over the top of what you think's a nevus, which you could not possibly see if you just used a color image. And that's why autofluorescence is such a fundamental important thing to use. If you use ultra-wide O-field OCT imaging, once again, you can see what looks like a normal nevus on the left. You see drusen over the top of it. The drusen is whitish, it's not orangey, so it's not likely to be lipofuscin, but you can't be sure. As soon as you look at the ultra-wide field OCT, you can see categorically that that is a nevus with overlying drusen. And you know for sure, you can just monitor that patient routinely. Other examples here is a retinal tear in the temporal periphery. And here's an atypical retinoschisis. It's a rather odd one here. But again, once you carry out the OCT scan in the periphery, it very clearly shows you this is just a retinoschisis. Another choroidal nevus here. And again, is that orangey in the center? Difficult to tell. But when you go and do the OCT, you can immediately see that is a nevus and just needs monitoring as such. And again, you see the composite scans you will get up on the software here. So you've got the color image, you've got the bottom, you've got it magnified at the top, you've got a volume scan, and you've got a line scan. So all of these details, you see how the study layout image has changed at the top there. And so all of this information allows you to make a much more informed decision. To diabetic retinopathy, this is really, really important nowadays to optometry, because normal patients, the diabetic screening committee are now looking at saying normal patients only need to be monitored every 2 years. But we know many, many times patients who are defined as R0, M0, P0, they've got no diabetic retinopathy, but that's only in the area that the screening committee have looked at. If you go beyond that, you will often see an awful lot more diabetic retinopathy. And these patients who've been classified as normal are not going to be seen for 2 years, and yet they may have pathology. And we know categorically, and there've been many papers published on this, that changes in the periphery are precursors of more aggressive change in the center. So it's so important with all our diabetic patients that we are looking at that periphery. And again, with ultra-wide field imaging, OCT imaging, we can see what the influences are of that diabetic retinopathy in the periphery. So we should be seeing all patients, we should be ultra-wide field examining all diabetic patients, and we should be referring them back to their diabetic clinics or their diabetic nurses if we're seeing changes in the periphery. So I just want to show you a couple of other images of beautiful sort of peripheral signs of OCT and the information it gives us. And you can see the center image in the middle there of beautiful changes in the vitreous and the area we can see with these images. And then more peripheral change. And once again here, just look at the amount of tractional force on that retina in the periphery. Now, I want to just finish by showing you another paper that's come out recently. And these are great because if you actually look again, 69% of the eyes in this study demonstrated pathology only in the periphery. And the ultra-wide field data that was obtained from those eyes led to a change in decision-making in 84% of the cases. So that pathology is out there and we must be looking for it all the time. So just 3 quick cases here. We've got a retinal hole in the center there, beautifully imaged, but we've also got a retinal hole that hadn't previously been noted out in the periphery. What's it like? Is it a problem? Well, in this case, the peripheral hole might have been seen routinely if ultra-wide field imaging had been used. It hadn't been seen before on normal. With peripheral OCT, some questions can be answered. Is the vitreoretinal traction present? No. What's the degree of that traction? Minimal. Is there fluid under the retina? What amount of fluid is present? The peripheral OCT answers all those questions. So that more complete data that the clinicians got can now be used in planning the surgery. As it happened, that patient went on to have both holes repaired, but the periphery had a retinopexy on it first to seal it, to make sure there was no problem going on there. Again, in this patient, peripheral OCT confirmed the detachment, but was also able to confirm that there were no other breaks, tears, limitations that would cause problems if it was only carried out in that one area. So the benefits here were that the retinal tears and breaks may not resolve if there are additional tears or holes elsewhere in the retina. The surgeon can therefore be much, much more confident of a successful repair with this extra knowledge that's there. Post-op follow-up much, much easier, and therefore the patient was more accurately treated. In case 3, we've got a 41-year-old white man. He's referred with suspected retinal detachment. If it's retinal detachment, this is urgent. This needs treatment. If it's a retinoschisis, shouldn't have been referred in the first place. Going to block the clinic up. Peripheral OCT imaging immediately showed this was just an age-related retinoschisis. The peripheral OCT confirms no associated retinal holes or detachments present. So we could have looked at that. We could have said, keep him out of the clinic. We will just monitor him in the practice. So without the imaging, fair enough, many would have referred because you cannot be sure what additional pathology may be present. It gives you the opportunity of definitive diagnosis. Maybe at a eye clinic, they may have even used scleral indentation, this chap was saying. But this allows you to make an accurate diagnosis. Decisions can be made to routinely monitor, and the patient, importantly, is rapidly reassured and relieved. Now, final thought here, and thanks to my colleague who allowed me to show this today with the patients, with his permission and the patient's permission. What can you see here? Here's a question. There's a number of options. The lower periphery definitely looks detached, as does the macular region quite severely. But is it a macular dystrophy? Is it a schisis? Is it an AMD variant? Is there a central detachment? Is this a lower peripheral detachment spreading off to a macular off detachment? We can make suppositions to this. What we need is the OCT image and an ultra-wide field OCT to look at what's going on in the base. We don't have that privilege currently in this image. That's why multimodal imaging with OCT built in as well would just answer those questions. It would allow us much, much more accurately to see what is going on and to make the right clinical decision. So just in summary, OCT is fast becoming a vital element in everyday optometric practice. I think in 10, 15 years' time, it will be as common as it was in my day when I was at university, and they were just bringing in AirPuff NCT. It was novel in our day. You wouldn't think of not doing eye pressure now. OCT is going that way. But ultra-wide field retinal imaging is absolutely as vital. And it's absolutely essential for ensuring a patient's retinal health, not just in the center, but in the periphery. If the periphery is not viewed, then you should make your patient aware of the clinical limitations when you are basing your judgment. If you say to a patient, your eyes are healthy, and you've only looked at, say, 40, 50% of the retina, the patient has a right to that knowledge. So you should be telling them that. And I would ask you to reflect on whether you tell your patients that or not after this session. This recent survey I've gone on about, the Optos one, within the 2,500 subjects, the spectacle wearers within that cohort believed that we saw 75% of their retina on examination. So that's quite some thought. The people that probably should know, because they come and see us regularly, thought we always saw at least 75%. Now, obviously, use of both systems is the dream team. This is what we should be aiming for, this whole multimodal imaging concept. Having both systems in one device is greatly going to influence your efficiency and patient flow. And it allows for consistent comparison between the two modalities, and imaging referencing is totally accurate because you're using the same in both. Optos Silver, undoubtedly the gold standard. It's expensive and it's mainly hospital-based, but it's fast being seen as a vital device. And a lot of hospitals that are using it are now saying optometrists should be using similar versions out in practice. And, pushing to see us doing that. And I think it's something we need to be taking on board. Much visual impairment in the centre is as a result of central retinal changes, but probably there is just as much occurring in the periphery and is missed because it's never seen in the first place. Central retina is important, but the periphery is the anchor for that centre. And if that anchor is not working properly, things are going to float away and we could see permanent damage in the centre. Often central change begins in the periphery, and that could be addressed earlier and sorted out earlier, so long as we look at that periphery. And multimodal imaging allows for much more accurate diagnosis and looking at that periphery and looking at its relevant action in the centre. So that allows us to plan treatments, plan referrals better. It aids the consultant and it allows for greater reassurance and reduced angst for the patient. That's all I have to say for today. Thank you very much for taking part. I think we may have some questions now. So if we just move back to Ian.
Sure, Simon, thank you very much. We've got stacks of questions actually, so we'll try and zip through these and get to as many as we can. First few are about dietary supplements. So is there a particular dietary supplement that you would advise for the patient? And second question is how does that fit in with current college guidance regarding supplements?
I think when it comes to supplements, the important thing is that they are AREDS2 compliant, in my opinion. The two things I go by is that we are not just willy-nilly prescribing supplements. I occasionally get patients would come in and say, oh, I'm taking lutein. Well, lutein on its own is really not going to do a great deal. So I think we've got to look at the AREDS2 formulation. And the second thing I would say is look at what your local eye clinic is recommending, because there's nothing worse than an eye clinic saying, we'd like you to take the following supplements. Then the patient comes to see you and say, well, we don't stock those. We stock Joe Bloggs' supplements because they're better, because that just puts confusion in the mind of the patient. So the two strands I would always say is make sure that we're using what is recommended as the latest right thing to be using for the patients. And obviously AREDS2 formulation is important, but also talk to your local clinic and say, well, what are you recommending? Because we want to tell a consistent story to the patient. And I think also going to the college thing, we really need to always follow your college guidelines in sync with what's happening locally. And there was a wonderful flow diagram came out. It's still around. It was in an AOP article a while ago, and I still use it. It's a very, very accurate flow diagram. I think I've just seen it actually used in a college presentation a while back. And it's, if you can get hold of it, I would recommend it. And it just takes you through the whole process in terms of whether you should be really talking about dietary change with the patient or whether you should be using nutrition supplements. And one of the things I do find very often when you look at that flow diagram is only a very small percentage of people that should be on dietary supplements. And the other thing I would say at this stage, very, very important, optometrists are really expensive beasts, as we all know. And whether you want your optometrists in the practice talking about curly kale and collard greens and carrots is one thing. I would always recommend that you have people, you have other members of staff who are trained to give this advice that you can pass the patient on to. So for years, I've gone on about how we should have stop smoking consultants in our practice. I sat on my PCG stop smoking service years ago when they used to pay us handsomely to make people stop smoking. And it's something that every single practice should have had for at least a decade now. And if you haven't got somebody who can talk to patients about giving up smoking and its benefits, and you don't know where to refer people to within your local CCG, you really should be doing that.
Thank you, Simon. It's nice to see the cases that you presented, but a question here from Melanie. Any studies that have been done comparing OCT pictures from patients who have been started on a supplement, so pre and post treatment with that you're aware of? The
case study I showed you I presented that as a poster at ARVO in Seattle and at the EAOO conference, and there are various papers about drusen regression, both centrally and periphery, that have been published. Off the top of my head, I can't name those, but if people want those, then one of the things what I do is, if you Google Drusen regression, you will see a whole series of papers on that, on those there.
Thank you, that's really helpful. Chris is interested to know what you meant by the term scuffing in the earlier part of your presentation.
I tend to try not to use clinical words. Patients understand what scuffing means, and so when the image is looking slightly blurred like that, the retinal surface is not flat. It's not got a sheen to it. So if you just took a Brillo pad, I've got a piece of MDF in front of me here. If I took a Brillo pad and just rubbed that MDF, it would look furry and scuffed. And that's what I mean when you're looking straight on at that. And when you look at that in cross-section in an OCT, you can see how that surface is looking sort of rippled. So it's breaking up the surface. So I use lay terms. When I talk about rods and cones with patients, I talk about a pile of CDs with a lollipop stick on top. And I think these lay terms, I try and use those.
Okay. A couple of questions about holes. So should we now refer all atrophic round holes, and should all holes with lattice degeneration be referred?
Absolutely not, and absolutely not. Atrophic holes do not normally lead to retinal detachments, and again, you will find evidence of that. If you Google atrophic holes, you will find quite a few papers published on the incidence of retinal detachment as a result of retinal holes. Whether that changes or not with ultra-wide field OCT will be an interesting thing over time, because we can see so much more of what's going on around that hole. But atrophic holes tend not to. I think with holes within an area of lattice degeneration, it's the analysis that you carry out at that time. So as I said at the time, always magnify areas of lattice degeneration up so you can have a really good look at what's going on. And if you're using ultra wide field imaging, you can look at the different depths that are there, and you can see what's happening down at RPE level. You can see whether there's any pigment forming around those holes. Bearing in mind, again, the age and the prescription of the patient. If they're -6 and 50 years old, vitreous traction is bound to be happening. And one of the things I think that really almost shook me when I looked at ultra wide field OCT is just the sheer forces that are at play on the surface of the retina as that vitreous peels away. I mean, it really is. I used to sort of just pull on the back of my hand and show patients, but yeah, you grab hold of the back of your hand and give it a real hefty tug and it'll hurt. And, you know, you see that's the sort of thing that's going on. So it's got to be a judgment call. Is the patient symptomatic? If the patient's not symptomatic, what's the consultant going to do with that? And I think one of the questions you must always ask yourself is, if I refer this patient, what is the eye clinic going to do with that patient? And if you're referring them just in case something happens and protecting yourself from the GOC, that's not a good referral. If the patient is symptomatic, has got a lot of lattice, has got a high prescription, you know, you're looking at the probabilities there. And so you could justify the referral on those grounds. If it's, well, it's a hole, it's in lattice, I'm going to refer it. No, you need to make a judgment call. And if you've made the right judgment call by asking yourself the right questions, coming to the right answers, noting those down on the patient record card and what you've made the patient aware of, then you've got nothing to fear by monitoring that patient, even on a routine basis.
Okay, Simon, are you dilating every patient, and how do the images degrade with lenticular changes?
I very rarely dilated patients, very rarely, because with ultra wide field imaging, and especially if you do what we call eye steering as well, it is very easy to get out to the ora serrata on quite a regular basis. So I have to say, I did have a box of tropicamide and it went out of date. So I would dilate when it was necessary, but in the vast majority of cases, I will say I did not dilate, and I have never had a problem as a result of it. But then I have been using these systems for 25 years. And so, you know, with time comes sort of confidence, if you like, not arrogance, confidence. But I would think in the early days, people are so used to wanting to judge things with the Volk lens as well. I would never, ever say, don't dilate. And that's an absolute categoric. And sorry, what was the second part?
I'm not sure there was a second part to that.
Okay.
How do the images degrade with lenticular changes?
Because it's a confocal imaging system, one of the beauties of confocal systems is that they do not degrade anywhere near as much as standard camera systems with cataract. And in actual fact, autofluorescence can be a very, very good indicator of development of nuclear sclerosis cataract, but that will take too long to explain today.
Okay. I don't think we've got time for too many more, but a slightly provocative one here. Remote imaging, in inverted commas, is a bit of a con, really. Even if you can press the button from a distance, in the case of Optos, you still have to manipulate the patient's head into the instrument. So just if you had any thoughts on that.
Yeah, I would love to go to their practice and indulge in some training with them, because you do not need to manipulate a patient's head if you've given the patient good instruction. Sometimes you will need to move the patient around, but in actual fact, if you go onto the Optos website and look at their training on how to position patients, you will get an awful lot of knowledge on how to position the patient correctly. You shouldn't need, in the vast majority of cases, to manipulate a patient's head. That was in the old style instruments. With the new instruments like Monaco that actually have a chin rest as well as a brow bar, and much like more conventional systems we use, it's not necessary.
Great. I think that's,
and you know me, Ian, I'm never controversial. I never have been.
Never. I think that's a great point to pause on the question. So thank you, Simon, for your insight. If anyone has any further questions about this webinar, please email events@aop.org.uk. Remember that the content will be available as a recorded piece. And we've got another 5 interactive CT points available throughout the rest of the day. Next session will start at midday and will be about barriers to myopia management. So look forward to seeing you all in 15 minutes or so. Thank you very much.